Learning outcomes. Dear students, after studying this module, you shall be able to know about what is ADHD, that is Attention Deficit Hyperactivity Disorder, symptoms of ADHD, factors contributing to ADHD, and treatment for ADHD. First, we shall start with the introduction. The behavior disorders have been the focus of a great deal of research, probably because children with these disorders can be quite difficult to deal with, and their behaviors can exact a heavy toll on society. Among the three highly found behavior disorders, which are attention deficit hyperactive disorder, conduct disorder, and oppositional defiant disorder, ADHD, Attention Deficit Hyperactivity Disorder, is one of the frequently encountered behavior disorder. These are distinct disorders, but they often co-occur in the same child. According to a study conducted by Jyotsna and Panikkar in the year 2013, the prevalence of ADHD among primary school children was found to be 11.32%. Prevalence was found to be higher among the males, that is 66.7%, as compared to that of females, that is 33.3%. The prevalence among lower socioeconomic group was found to be 16.33%, and that among middle socioeconomic group was 6.84%. The prevalence was highest in the age group of 9 and 10 years. Now, what is attention deficit hyperactivity disorder? A major focus on socialization is helping children learn to pay attention, control their impulses, and organize their behaviors so that they can accomplish long-term goals. Some children have tremendous trouble learning these skills, however, and may be diagnosed with attention deficit hyperactivity disorder or ADHD. A child's difficulties in paying attention and his impulsivity go far beyond what is normal for a child in his age. Most elementary school age children can sit still for a period of time and like to engage in at least some games that require patience and concentration. They can inhibit their impulses to jump up in class and talk to other children or to walk out into busy traffic. Children with ADHD cannot do any of these things. The behavior has a character of being driven and disorganized, following one whim and then the next, as is common in children with ADHD. There are three subtypes of ADHD. Most children and adolescents with ADHD have the combined type, which is defined by the presence of 6 or more of the symptoms of inattention and 6 or more of the symptoms of hyperactivity, that is impulsivity. The predominantly inactive type is diagnosed if 6 or more symptoms of inattention, but fewer than 6 symptoms of hyperactivity, impulsivity are present. Some researchers argue that certain symptoms indicating a sluggish cognitive tempo are also important parts of the predominantly inactive type. These symptoms include the slow retrieval of information from memory and slow processing of information, low levels of alertness, drowsiness, and daydreaming. The predominantly hyperactive impulsive type is diagnosed if 6 or more symptoms of inattention are present. Now, the symptoms of ADHD. The symptoms of attention deficit hyperactivity disorder fall into 3 clusters: inattention, hyperactivity, and impulsivity. First is inattention, that is, does not pay attention to details and makes careless mistakes, has difficulty sustaining attention, does not seem to be listening when others are talking, does not follow through on instructions or finish tasks, has difficulty organizing behaviors, avoids activities that require sustained effort and attention, loses things frequently, is easily distracted, is forgetful. Next is hyperactivity, that is, fidgets with hands or feet and squirms in seat, leaves his or her seat when it is inappropriate, runs around or climbs excessively, has difficulty engaging in quiet activities, often acts as if driven by a motor, and often talks excessively. Third is impulsivity, that is, blurts out responses while others are talking, has difficulty waiting his or her turn, often interrupts or intrudes on others. Many children do poorly in school because they cannot pay attention or quell their hyperactivity. They do not learn the material they are being taught and perform below their intellectual capabilities. In addition, 20 to 25% of children with ADHD have serious learning disabilities that make it doubly hard for them to concentrate in school and to learn. Some children with ADHD have extremely poor relationships with other children and are rejected outright by other children. When interacting with their peers, children with ADHD are disorganized and never finish anything. They are intrusive, irritable, and demanding. They want to play by their own rules and have explosive tempers, so that when things do not go their way, they become physically violent. The behavior problems of some children with ADHD are so severe that they may also be diagnosed with the conduct disorder. Children with conduct disorder grossly violate the norms for appropriate behavior toward others by acting in uncaring or even violent ways. Between 45 and 60% of children with ADHD develop conduct disorders, abuse drugs, or become juvenile delinquents. The conduct problems that some children with ADHD have persist into adulthood. ADHD has become a popular diagnosis to give to children who are disruptive in school or at home, and the media attention on ADHD over the past decade has made it seem that there is an epidemic of this disorder. However, various epidemiological studies indicate that only 1 to 7% of children develop ADHD. Boys are about 3 times more likely than the girls to develop ADHD in childhood and early adolescence. Boys with ADHD tend to have more disruptive behavior than girls with ADHD, and this may lead to an under-identification of ADHD in girls. ADHD is found across most cultures and ethnic groups. The long-term outcomes for children with ADHD vary considerably. The symptoms of ADHD persist from childhood into young adulthood for about 3/4 of these children. Adults who were diagnosed with ADHD as children are at increased risk for antisocial personality disorder, substance abuse, mood and anxiety disorders, and marital problems, traffic accidents, legal infractions, and frequent job changes. Adults who have ADHD are at a higher risk for depression, anxiety disorders, substance abuse, and antisocial personality disorder. However, many children grow out of ADHD by early adulthood. Their ADHD symptoms have passed, and they go on to lead normal, healthy lives. Now, we shall discuss about the factors contributing to ADHD. Are the factors contributing to ADHD? First, biological contributors. Second, psychological and social contributors. Now we shall discuss these contributors in detail. Biological contributors to ADHD. ADHD was formerly referred to as minimal brain damage under the assumption that the attentional deficits and hyperactivity were due to mild brain damage. Most children who developed ADHD, however, have no history of brain injury, and most children with some brain injury do not develop ADHD. Modern studies have shown that children with ADHD differ from children with no psychological disorders on a variety of measures of neurological functioning and cerebral blood flow. The areas of the brain most likely involved in ADHD include the frontal lobes, the caudate nucleus within the basal ganglia, the corpus callosum, which connects the two lobes of the brain, and the pathways between these structures. Each of these brain areas and pathways play an important role in the deploying of attention, the regulation of impulses, and the planning of complex behavior. One hypothesis is that children with ADHD are neurologically immature. Their brains are slower in developing than are other children's, and this is why they are unable to maintain attention and control their behavior at a level that is appropriate for their age. This immaturity hypothesis helps explain why the symptoms of ADHD decline with age in many children. The neurotransmitter that is most considerably implicated in ADHD is dopamine, although serotonin seems to play a role in aggressive behavior. It does not appear to be central to ADHD. ADHD runs in the families. Between 10 and 35% of the immediate family members of children with ADHD are also likely to have the disorder. Several other disorders also tend to run in the families of children with ADHD, including antisocial personality disorder, alcoholism, and depression. Toy studies and adoption studies also suggest that genetic factors play an important role in vulnerability to ADHD. It is not clear exactly what factors of the ADHD syndrome are inherited, whether they are problems with attention, hyperactivity, impulsivity, or aggressivity. Molecular genetics studies suggest that the dopamine transporter genes may be abnormal in ADHD. Many children with ADHD have histories of prenatal and birth complications, including maternal ingestion of large amounts of nicotine or barbiturates during pregnancy, low birth weight, premature delivery, and difficult delivery leading to oxygen deprivation. Some investigators suspect that moderate to severe drinking by mothers during pregnancy can lead to the kinds of problems in inhibiting behaviors seen in children with ADHD. As preschoolers, some of these children were exposed to high concentration of lead when they ingested lead-based paint. The popular notion that hyperactivity in children is caused by dietary factors such as consuming large amounts of sugar has not been supported in controlled studies. A few studies do suggest, however, that a subset of children with ADHD have severe allergies to food additives and that removing these additives from these children's diet can reduce hyperactivity. Next is psychological and social contributors to ADHD. Children with ADHD are more likely than children without psychological disturbances to belong to families in which there are frequent disruptions such as changes in residence or prenatal divorce. Their fathers are more prone to antisocial and criminal behavior, and the children's interactions with their mothers are more often marked with hostility and conflict. Some investigators argue that there is a non-genetic form of ADHD that is caused by environmental adversity. Others argue, however, that both ADHD and difficult family environments are the result of genetic predispositions to problems with lack of control. Certainly, having a child with ADHD can impose significant stress on parents and a family. The explosive temper, the impulsive, dangerous activities, the school difficulties, and the rejection by peers can lead to constant conflict between the children and the parents and the siblings. Family members may not understand that a child with ADHD cannot voluntarily control his or her behavior simply when told to, and thus may blame the child. Much of the treatment of ADHD in a child involves the parents and sometimes siblings in reshaping the family's interactions to reduce the symptoms of ADHD in the target child and to improve overall family functioning. Now, we shall discuss about the treatments for ADHD. The most common treatment for ADHD in children is the use of stimulant drugs such as Ritalin, Dexedrine, and Adderall. It may seem odd to give a stimulant drug to a hyperactive child, but between 70 to 85% of ADHD children respond to these drugs with decrease in demanding, disruptive, and non-complaint behavior. They also show increases in positive mood, in the ability to be goal-directed, and in the quality of their interactions with others. The stimulants may work because they increase dopamine levels in the synapses of the brain by enhancing the release and inhibiting the reuptake of this neurotransmitter. The side effects of stimulants include reduced appetite, insomnia, edginess, and gastrointestinal upset. They can also increase the frequency of tics in children with ADHD. Some youth abuse stimulants, and recent reports have focused on college students who fake ADHD in order to get a prescription for stimulants, which they use to help them stay awake and work long hours in college. Nationwide, the number of children prescribed stimulant medications increased by 200 to 300% in the past 2 decades. Some researchers have argued that this greater use is due to an increase in recognition of the disorder and treatment seeking for children with ADHD. Others argue that it represents an inappropriate overuse of drugs, particularly for children who are difficult to control. However, there is a scant empirical evidence on which to judge these competing claims. Other drugs that are used to treat ADHD include clonidine and guanfacine. More recently, atomoxetine, which inhibits the reuptake of norepinephrine, has been approved for use in the treatment of ADHD. Antidepressant medications are sometimes prescribed to children and adolescents with ADHD, particularly if they also have depression. These drugs have some positive effects on cognitive performance, but are not as effective against ADHD as the stimulants. Bupropion is an antidepressant with particularly strong effects on dopamine levels, and it appears to be more effective against ADHD than some of the other antidepressants. Unfortunately, the gains made by children with ADHD when treated with medications alone are short-term. Longer-term gains can be had by combining stimulant therapy with behavior therapy that focuses on reinforcing attentive, goal-directed, and pro-social behaviors and extinguishing impulsive and hyperactive behaviors. Parents can be taught behavioral methods for promoting positive behaviors and extinguishing maladaptive behaviors in their children. In addition, parents' own psychological problems and the impairments in parenting skills that these problems create may be the focus of psychosocial interventions for the children with ADHD. Behavioral training programs for children with ADHD and their parents have been shown to improve functioning significantly in the children and their families. For example, the child and his parents might develop a contract that says that every time the child complies with a request from his parents to wash his hands, to set the dinner table, and to put away his toys, he earns a chip. At the end of each week, he can exchange his chips for toys or fun activities. Each time the child refuses to comply, however, he loses a chip. If the child throws a tantrum or becomes aggressive, he must go to his room for a timeout. Such techniques can help parents break the cycle of arguments and perhaps physical violence. These techniques also help children learn to anticipate the consequences of their behaviors and to make less impulsive choices about their behaviors. Several studies suggest that the combination of stimulant therapy and psychosocial therapy is more likely to lead to both short-term and long-term improvements than either type of therapy alone. For example, in one multi-site study, 579 children with ADHD, average age about 8 years, were randomly assigned to receive the combination of Ritalin and behavior therapy. One of these therapies alone or routine community care. After 14 months of treatment, 68% of the children in the combined treatment group showed a reduction in or complete discontinuation of their ADHD behaviors, such as aggression and lack of concentration. In the medication alone group, 56% showed a reduction in or discontinuation of symptoms. Behavior therapy alone led to a reduction of symptoms in only 34% of the group members, and only 25% of the children given routine community care showed reductions in symptoms over that time period. Now we will end this module with the summary. The behavior disorders include attention deficit, hyperactivity disorder, conduct disorder, and oppositional defiant disorder. Children with attention deficit hyperactivity disorder are inattentive and overactive. Many do not do well in school and their relationships with their peers and are extremely poor. Some children with ADHD disorder grow out of this disorder, but some continue to show the symptoms into adulthood, and they are at high risk for conduct problems and emotional problems throughout their lives. The two therapies that are effective in treating ADHD are stimulant drugs and behavior therapies that teach children how to control their behaviors. The combinations of medications and behavior therapies appears to lead to the most long-lasting improvement.